All right. Well, welcome everybody to this month's edition of It's a Brain Thing. I'm honored again this month, for the second month in a row, to welcome a friend of mine and a colleague, Dr. Bojrab. He and I went to Indiana University psychiatry residency together, so we pestered each other for 4 years or so. Well, 3 years. You're ahead of me. So.
Exactly.
But I've asked him to come and speak to us tonight about sleep disorders and all different types of things. And of course, at the end, there'll be time for questions, so you guys can ask anything you'd like. So I'll turn it over to Chris.
Thank you very much. It's a pleasure to be here with you all this evening. Again, I'm Chris Bojrab. I'm a psychiatrist in general practice in Indianapolis, and I'll start out with a disclaimer that I am not a sleep specialist. I have no formal training in sleep, but sleep is something I've really been interested in clinically because I've become increasingly convinced that regardless of how you take care of patients, or if you're a patient with a variety of different types of medical conditions, sleep really impacts nearly everything that we treat. And sort of selfishly, I'm interested in treating sleep disorders because when I treat a person's sleep disorders, if I get them sleeping better, more effectively, more efficiently, everything else I'm trying to treat becomes easier to fix. So I thought we would, I don't have any formal notes or slides or anything. I thought we just would sort of talk about sort of the state of affairs with where we're at now in our understanding of the importance of sleep and the treatment of sleep disorders, some of the major different sleep disorders that we see, and sort of what our approach is for the treatment of things like insomnia now, compared to what it was just 5 or 10 years ago, because it's really changed a fair amount. Sleep disorders are pretty common. Probably insomnia is the most common of the sleep disorders, and insomnia really can come in a lot of different flavors. This is not simply about trouble falling asleep. When you talk about insomnia, that's usually the first thing that people think about is I'm having trouble falling asleep. But if you look at all of the types of sleep disorders that people have, falling asleep is only about a third to a quarter of the problem. People also have difficulty maintaining sleep. People have difficulty with non-restorative sleep. People have difficulty waking up too early in the morning and then not being able to fall back to sleep. And in terms of the scope of the problem, probably somewhere around 30 million Americans will suffer from insomnia in the course of a given year. Now, for most of those patients, it's what we refer to as a transient insomnia, meaning I'm having trouble falling asleep, staying asleep, or early morning awakening. That happens once in a while. When we get into a pattern of what we call chronic insomnia, we're talking about patients who are having typically 2, 3, 4 nights a week where they're having more significant, more substantial problems falling asleep, staying asleep, or having a good night's sleep that restores them and allows them to function optimally the next day. Now, interestingly, as common as this problem is, people are really unlikely to go in and complain to their doctors about it. It's almost like people just sort of assume that, given our busy lifestyle, we're supposed to feel tired. We're supposed to not sleep well. So they've done these large-scale telephone surveys, like the Gallup organization that does all the telephone surveys, where they've called up people across the country and randomly asked them about the quality of their sleep. And they identify these folks that meet criteria for some clinically relevant insomnia problem. And they ask them, how often have you specifically made an appointment to go in and talk to your doctor about this problem? 5% of them. Almost 70% of them have never even mentioned it while they were in an office for something else. So if they're in for their annual checkup and the doc asks, how are things going? Even if they're having insomnia symptoms, almost 70% of patients won't mention it. People just sort of assume that's what's supposed to be the state of affairs. So sleep's really important for a number of reasons, only some of which we understand. We know that sleep serves sort of the general restorative function. People that don't sleep obviously have trouble feeling fatigued the next day, but it also impairs concentration. It impairs your ability to focus. It impairs your ability to remember things. It impairs your ability to learn new information. It also contributes significantly to other medical problems. There's mounting evidence that chronic pain disorders are much worse in patients who aren't sleeping well. Depression can be caused by lack of sleep. Anxiety problems can be caused by lack of sleep. Not sleeping well over the course of time can dramatically increase the risk of somebody becoming addicted to alcohol or drugs. People that don't sleep well are also at markedly increased risks for accidents, especially motor vehicle accidents. There was a study that was done a few years ago out at Harvard Medical School where they looked at the house staff. They looked at the interns and residents that were working there for Harvard Medical School. And they had them track over the course of 4 years car accidents. How many times were they in a car accident? And people were 4.5 times more likely to be in a car accident the night that they were post-call, the night that they hadn't slept well. So it really has a dramatic effect. And they're starting to look at this from a safety issue concern for the general public. If you look at hospital errors that are made, dispensing errors in pharmacies, giving the wrong drug in a hospital, there's a marked spike on the likelihood of those things happening on second or third shift compared to daylight shifts. So we don't function great when we're being asked to fight our circadian rhythms and when we're asked to be awake in the middle of the night, nor do we function very well if we're not getting a good night's sleep. If you look at what the normal sort of pattern of sleep is, in terms of how long should it take me to fall asleep, most of the time, a healthy person with a good sleep pattern should fall asleep probably within 10 minutes of going to bed, 10, 15 minutes. People that fall asleep terribly quickly after getting into bed, that can be a sign that they're having what we refer to as excessive sleepiness. They're so tired that they fall asleep faster than expected when your head hits the pillow. People should also sleep soundly through the night. Now, if somebody wakes up once during the middle of the night and they're awake for 5 or 10 minutes and they say, hey, I saw one of those commercials on TV for those sleep pills. Do I need me one of those sleep pills? No, that's considered within the normal realm of normal, healthy sleep. So when we're talking about patients with insomnia, we're really talking about people that have more severe disturbances. And a lot of people with insomnia don't just miss out on 15 or 20 minutes of sleep. They're missing out on hours of sleep during the night. Most patients really do function best sleeping 7 or 8 hours a night. There have been various studies looking at this. There have been some studies looking at how much do people really sleep. Part of it falls out based on gender and race and where you live in the country. For example, there was a neat study that was done up in Chicago where they surveyed a bunch of residents of Chicago, and they actually had them wear these little devices that tracked how much they were sleeping and basically paid attention to whether or not they were moving around, what their breathing pattern was like. And it asked people to self-rate their sleep. First of all, we're terrible at rating the quality and quantity of our sleep. I know this from personal experience. I was diagnosed with sleep apnea a number of years ago. My wife's like, you need to go in for a sleep study. She's a nurse. She said, she goes, you're snoring like a lumberjack. You're having prolonged apneic episodes, meaning when you stop breathing in the middle of the night, you sort of start gasping, and I think you've died. You need to go in and get a sleep study. I said, okay, I can believe it. I got the habit of snore, right? I got the body style. If you're a big guy. Little trivia, if you have a neck size greater than 17, there's probably about an 80% chance you've got sleep apnea. So I said, hey, I fully believe I could have sleep apnea, but I was asymptomatic. Because what do you normally think of with sleep apnea? People being tired, people falling asleep, people need to sleep more than usual. That wasn't me. I had tons of energy. I'm sort of a short sleeper. I sleep most of the time. This is the do as I say, not as I do. I sleep on average probably 5 or 6 hours a night. And there's about 10% of the population that really does get by fine on 4, 5, 6 hours of sleep each night. But the majority of folks function best on 7 or 8. And similarly, about 10% of people need maybe 9 or 10 hours of sleep. So I said, gosh, I'm sure I snore. I could believe I have sleep apnea. But I didn't feel symptomatic from it. Felt fine, didn't feel tired. So I went in for a sleep study. And they said, you had nearly 80 respiratory problems per hour during the course of the night. Now, if you have what's called an apnea-hypopnea index, which means how many times do you sort of stop breathing or almost stop breathing, if that's more than 5 or 10 per minute, that's considered, 5 or 10 per hour, that's considered unusual. That's considered atypical and not normal. Mine was up there like, 60, 70, 80. So then the test they do the next morning, which is called the MSLT, the multiple sleep latency test. Anybody here have a sleep study? Okay, a couple of you. Remember, did you guys do the thing the next day where they asked you to take naps during the day?
Didn't have to go that far.
Didn't have to go that far? Well, that's one of the ways. The sleep studies are broken down into 2 things. Sleep studies are also called polysomnograms. Poly meaning many, somna meaning sleep, and gram a measurement. So they take many different measurements of you while you're sleeping. They put EEG leads, they measure brainwave activity. They put on a heart monitor, measure your pulse. They measure your breathing. They measure how much you're moving around. They measure oxygen saturation in your blood to see how well your lungs are oxygenating your blood when you're sleeping. And then the following day, what they'll do is do sometimes what's called a multiple sleep latency test. And in this study, what they do is they put you in a quiet room, let you hang out there for a while, and then they'll say, okay, get into bed, we're going to turn the lights off, see how long it takes you to fall asleep. And again, I said the average person takes them, maybe 5, 10, 15 minutes to fall asleep. So they do this, and they have you take these naps 3, 4, 5 times that day. So the sleep specialist calls me up a couple weeks later after he read the sleep study. He's like, Chris, I just read your sleep study. Are you still working? I said, well, yeah, I work a lot, as a matter of fact. He's like, most people with sleep apnea, this bad, are on disability. I'm like, you're kidding. I said, I feel okay. He's like, oh, it's because you're young and you have energy. He said, but we really need to get you on CPAP, because sleep apnea isn't just bad because it makes you tired the next day. Sleep apnea is bad because it tremendously increases your risk of really bad things happening to you medically. Heart attacks, stroke, high blood pressure, developing a condition called primary pulmonary hypertension, which basically means because of poorly oxygenating your blood at night, the tissue in your lung changes and becomes a little tougher to push blood through. So it becomes so hard to get blood pushed through your lungs and be oxygenated that you can develop a specific type of heart failure. And about the only way to fix this is a lung transplant, which we do now, but you really don't want to be involved with that if you can avoid it. So I said, okay, I'm asymptomatic, but I don't want to have an early stroke, heart attack, or buy myself a new pair of lungs for my 50th birthday. So great, I'll go on CPAP. And he said, but about your sleepiness? He goes, you don't feel sleepy? No. He said, how long do you think it took you to fall asleep on your multiple sleep latency test? Oh, I don't know, 5, 10, 15 minutes? 3 minutes. My point is, people are sometimes really poor judges of how they sleep and the quality or quantity of their sleep. So one of the best things you can do, ask your bed partner. Ask their spouse about their sleep patterns, and sometimes you get a very different story. So what do we do when somebody comes in and we're sort of evaluating their sleep? What are some of our recommendations? Well, our first recommendations are for good sleep hygiene. Sleep hygiene refers to non-medication things that you can do to help improve the quality and quantity of your sleep. And there's a lot of great recommendations. Number 1, go into bed and waking up the same time each day. Even on the weekends? Even on the weekends, technically. If you can get yourself more into a pattern, a regular daily routine of this is the time that I go to bed, this is the time that I wake up, that helps. Sleep begets sleep. What else? Just paying attention to your sleep environment. We're a pretty connected and wired world these days. So you try to dissuade people from having big screen TVs and Xboxes and stereos and computers in their bedroom. The bedroom should be for sleep and sex. That's about it. So your body just sort of behaviorally knows that when I'm here, that's what I'm here for. Having a room that's just sort of physically comfortable, having a room that's quiet, dark, cool. People tend to sleep better in a little cooler temperatures in general. Other things that you can do to pay attention to sleep hygiene, what you avoid ingesting late in the day. Nicotine, caffeine. Caffeine is a really common part of all of our lives. And it's funny because if you look at caffeine, if you look at the studies that have been done on caffeine, if it never existed before and somebody all of a sudden developed this new product called caffeine and brought it to the market, it would be a controlled substance. By the rules of the FDA, most likely, if caffeine were brought to the market today, it would be referred to as what's called a Schedule IV controlled substance. That means it would be lumped into the same category as things like Xanax or Valium or Klonopin or Ambien or Nesta, because it's that much of a reinforcing effect. And it's not a physiologically inert substance. That means it does affect your body. It can increase your blood pressure, your pulse rate, and really be disturbing to your sleep. Well, Doc, it's okay because I stopped drinking coffee after dinner. How long does caffeine stick around in your system? It takes about 20 to 24 hours to clear 95 to 99% of caffeine out of your body once you've had it. So we usually tell people if they're having trouble with sleep and if they do use a fair amount of caffeine, that's one of the first things we recommend they take a look at. We try to decaffeinate people, or at least try to have no caffeine afternoon. What else? Nicotine. Nicotine is sort of a misunderstood substance because it's both a stimulant a wake you up kind of substance, and a depressant, a relax you substance at the same time. So people sometimes that smoke say, well, I gosh, I have a smoke before I go to bed, it helps relax me. Well, it may feel like it's relaxing you, but physiologically what it's doing to your body is it's a stimulant, and it can hurt your sleep. What other kind of things do people resort to help with their sleep? Alcohol is probably the most common thing, right? Nightcap makes sense. A little glass of wine, a little cocktail late in the evening, relaxes me, helps me fall asleep. That is and isn't true. Alcohol turns out to be a pretty good way to knock yourself out. The problem is your body starts to metabolize alcohol within a couple of hours of having it, and you get into a little bit of a withdrawal state. And alcohol gets turned into different chemicals by your liver, some of which can be pretty disruptive to sleep architecture, meaning that it prevents you from getting into as deep of a sleep as you should, and it doesn't allow you to progress through the normal different stages of sleep. So alcohol will help knock you out, but you pay a price in that it worsens your sleep once you're already asleep. Other things that people use to help treat their sleep, over-the-counter medicines. Benadryl. Benadryl is an antihistamine medicine that people use for over-the-counter for allergies. And a lot of people will use it as a medicine to help with sleep or help them relax because it is a sedating substance. Benadryl turns out not to be a great long-term sleep medicine because you build up an immunity to it over time. And also because it tends to leave people feel a little bit fuzzy-headed the next day. And that's the problem with a lot of medicines that we use for sleep, whether they're prescribed medicines or over-the-counter medicines. Other things that people have used things like natural supplements like kava, valerian root, chamomile tea. All of these things have sort of mini Xanax-like effects. They can be helpful to some people, but that entire class of chemicals is very similar to the older class of sleep medicines. Now, our older class of sleep medicines are a class of medicines called benzodiazepines, and these are medicines that include the members of this family being such things as Xanax, Valium, Klonopin, Ativan, Librium. These are all anti-anxiety medicines that will help you fall asleep, but very similar to alcohol, they tend to be disruptive to your ability to stay asleep. So a lot of times people will go on these medicines, like one of the older class of those medicines, and find that initially for the first week or so it does help them fall asleep, but after that they build up a tolerance to it and it doesn't help them sleep so much anymore. And people that are maintained on them chronically find that, I'm falling asleep okay, but gosh, I'm still tired when I wake up in the morning. And it's because they've traded quality of sleep for quantity of sleep. So they may be sleeping more, but the sleep they're getting is not very efficient, and they're not getting to the deeper, more restorative stages of sleep. About 10 years ago, we saw the advent of a newer class of sleep medicines called the non-benzohypnotics. These are cousins of the old sleep medicines, but they're cleaned up versions. And these medicines were an advantage because they didn't do the bad things to our sleep architecture, to our ability to maintain sleep and to sleep well in the lower stages of sleep, like the old cousins did. So these medicines were preferable because they worked well at getting you asleep, and they did a better job of keeping you asleep, and you didn't tend to develop tolerance to them. They were a little bit less addicting or habit-forming, and they did not mess up the normal progression through the different stages of sleep. So they were a big advantage. But not without their own problems. These medicines, even though you're much less likely to build up tolerance to them, some people appear to do that. Even though they have a lower potential to become addicted to them, it's not impossible to become addicted to them. One of the complaints of some of these classes of medicines have been that they don't keep people asleep long enough. So a lot of people felt like they were getting more of a benefit falling asleep, but less of a benefit in terms of staying asleep through the course of the night. One of the newest sleep medicines on the market is a medicine that actually works on the melatonin system in the brain. People have heard melatonin. Melatonin is actually a hormone in the brain. And the way this works, it's interesting. It's a little complex, but it's interesting. In the back of our eye lies our retina, where our vision lives. And you have two major types of cells in the back of your retina. One type of cell that's better at sort of seeing color, and another type of cell that works more in black and white. But together, these different cells give us our visual acuity. They give us the ability to see color, to see sharp, crisp edges, and to detect movement in the environment. And that's the majority of cells in our retina. That's 99% of them. But 1% of the cells in the back of our eye are really old. Evolutionarily, they're really old types of cells. And the only things these cells do is they count how much light there is. And when light gets below a certain level, it sends a signal back to a different area of the brain using the brain chemical called melatonin. And melatonin turns on the circadian, you've heard of circadian rhythms? The part of the brain that regulates circadian rhythms is this structure with a big long name called the suprachiasmatic nucleus. That just means it's this cluster of brain cells that lives above the area where the two major nerves from your eyes come together. And this structure is in charge of being your body's timekeeper. And this sets our normal circadian rhythm. Our normal circadian rhythm isn't exactly 24 hours. Our normal circadian rhythm is actually just a little bit longer than that. So if we took us all and if we were to board up this room, turn the lights down about halfway, and keep us here for weeks or months, our body clocks wouldn't follow the normal 24-hour day that we have here on planet Earth. It would run just a little bit longer than that, probably 24 and a half, 25 hours. And eventually we would get out of sync with the normal day. So melatonin does two things in our brain. Number one, it resets that clock so we stay in sync with our day. And number two, it provides a signal to turn off the brain's alerting systems so we can fall asleep. And that's what this new class of medicine works on. It works on the brain's melatonin system. So we're getting smarter about figuring out ways of using medicines to help treat some of these sleep conditions. But again, none of these things work for everybody, and none of these things are without some potential for side effects. I mentioned that one of the reasons I'm interested in sleep is because sleep really impacts a lot of other areas, a lot of other disease states. As a psychiatrist, as somebody who treats diseases involved, such as depression or anxiety or schizophrenia or bipolar disorder, sleep is really a big part of all those disorders. For example, if we look at our patients that have what we call refractory depression, patients that have depression that despite our best efforts and our best medicines and our best therapy and our best forms of treatment doesn't get better over time, what percentage of those people do you think have a sleep problem? What percentage of those people do you think have sleep apnea in particular? It's about 20 to 24%. The overall rate of sleep apnea is more like around 5%. So a 4 or 5-fold difference in the prevalence of and how often we see sleep apnea just in that population. People have heard of fibromyalgia. Fibromyalgia is a disease state where people have multiple types of symptoms. They have pain symptoms. They have specific pain along certain trigger points in their body. They also tend to have a lot of problems with fatigue, muscular weakness. They seem to really respond slowly after an injury in terms of their ability to heal. They have really high rates of depression and anxiety. There's a lot of people that feel fibromyalgia may primarily be a sleep problem, because one of the things that you see pretty consistently in folks with fibromyalgia is that they don't get to the lower stages of sleep, what we refer to as slow wave sleep, or stage 3, stage 4 sleep. And the lower stages of sleep are really important, because our body, even though our body is at rest, on the outside, on the inside, it is really active, doing a lot of important things. During slow wave sleep, we do a lot of hormonal work for our body. Testosterone, we build a lot of testosterone during that short period of time that we're in slow wave sleep. Thyroid hormone, we build active thyroid hormone from inactive thyroid hormone a lot when we're in slow wave sleep. We're able to relax ligaments and tendons the best when we're in slow wave sleep. Growth hormone, which is important in our body's ability to grow cells, to build muscle tissue, to build lean muscle mass. We produce probably, of all the growth hormone that you produce as an adult, probably 80 or 90% of it you produce during that hour or so of slow wave sleep that you get each night. So imagine what people might look like if they're just not only if they're not having a problem or if they're not sleeping well, but imagine what people might look like if there's an impairment in their ability to get to that really high quality sleep. They might look tired. They might look achy. They might look sort of like they have muscular weakness, or they have trouble repairing tissues in their body after an injury. So that's one of the reasons that we're really interested in sleep, is because we know it has a dramatic effect on a lot of other kind of conditions, other kind of pain conditions. We know that when people sleep better, they tend to have less pain, they tend to use less pain medicines. When people aren't sleeping as well at night, they tend to rate their levels of pain as worse during the day. They tend to use more in the way of pain medicines. Same thing with anxiety. There have even been some studies suggesting that people that have chronic impairments in sleep have shortened life expectancies. In fact, if you look at people that sleep considerably less than 4 or 5 hours a night on a consistent basis, or if you look at people that sleep too much, if you look at people that sleep more than 10 hours a day on a consistent basis, they tend to live less long than the average person does. If you see people that are fighting their normal body clocks, if you see people that do shift work, people that work third shift, that takes a toll on people's bodies. There was a study done a number of years ago looking at emergency room doctors that worked swing shifts, who changed their schedule day, night, days, evenings, nights. And on average, they lived like 5 years less long than other physicians did. So fighting your body's natural sleep cycle and doing that on a consistent basis has potential risks. It may be medically dangerous in some ways. How are we doing on time here? 30 minutes there. Let me sort of pause at this point and just sort of open the floor up for any questions or comments that people have about either what we've talked about tonight or just other questions that people have come in with.
We have, in the last year, John and I have started taking some vitamins.
Mm-hmm.
Right Choice or something like that, health-wise vitamins.
Mm-hmm.
We take 3's prescribed, we take 2 pieces in the morning and then 2 at night. And I take them right at bedtime. And I have noticed since I've been taking them that I'll wake up throughout the night more frequently, wake up and see what time it is. Oh, I have some hours yet to sleep. And I go right back to sleep. And I do seem to have a little, well, I guess less fatigue, I wouldn't say more energy, but I think I feel a little better taking them over the last months now.
Uh-huh.
The person that sold us on them said, if you think you're not doing any good, stop taking them. Well, we haven't, because I think we do have, like I said, a little more energy, speaking for myself anyway. But what about that when you wake up like that and still get up just as early? So that's the question.
The question was about use of vitamins, use of supplements, and the extent to which you notice those things are helpful and may help to improve energy. But as was mentioned, maybe noticing waking up in the middle of the night, but being able to go back to sleep, waking up at the normal time in the morning, and in general feeling like your energy is overall better. That's probably okay. Again, waking up once in the middle of the night briefly and then being able to go back to sleep is probably not a huge impact on your overall night's sleep. So if somebody is missing out on 15, 20 minutes of sleep, that probably is not nearly as bad for a person as somebody who has a more chronic pattern of insomnia where they're having multiple awakenings during the night, waking up and maybe not being awake for 5 or 10 or 15 minutes, but maybe they're up for a half an hour, hour and a half, and maybe they do that a couple of times at night. And I always tell people that the proof's in the pudding. So certainly, if I have somebody that's in my practice that is taking a vitamin and they had an experience like that, I would say that's fine as long as you feel like your energy overall is better and it's not being significantly disruptive to your sleep. I wouldn't see that as being a problem.
I guess one comment I might make is make sure you know what's in the vitamin.
Yeah.
Because the other thing is it's possible if it's keeping you from sleeping as well, maybe there's some type of a stimulant that's in there, like ephedrine or I know ephedrine now is controlled, it's not easy to get, and probably a lot of these things don't have it, but pseudoephedrine, other things that can be kind of stimulating that then might give you more energy during the day, but then interfere a little bit with sleep.
Exactly, and a lot of the over-the-counter products that are sold do have various forms of stimulants in them, whether it's caffeine, ephedrine, pseudoephedrine, a Chinese herb called ma huang that is essentially ephedrine. So there are a variety of stimulating kind of substances, and they will make people feel better because it gives you a boost of energy, and so they like to put these things in there. These things are also sometimes included in some over-the-counter weight loss medicines like Metabolife. Right? I always used to think that we should send those folks fruit baskets at the holidays because they sent us so much business because people would take them and then develop anxiety disorders or something. Or drive people into sleep labs and so forth. And people just sort of lose track of the fact that caffeine can really have an effect. I mean, you see some of these kids coming in and their parents saying, I don't know why, little Johnny's just not sleeping. And little Johnny's drinking, 2 or 3 2-liter bottles of Mountain Dew each day. Maybe that's why little Johnny's not sleeping. Although it's interesting, a word about sort of the differences across the age range in terms of sleep. There really is a difference. If you look at how adolescents sleep, how young adults sleep, and how old adults sleep. Young adults tend to really have a circadian rhythm that's a little bit different. So our adolescents are teenagers that you can't get them out of bed in the morning and they want to stay up at night and sleep in later. That's actually probably dictated by biology. That's actually dictated partially by circadian rhythms. If you look at the natural circadian rhythms of adolescents, they tend to have a different sleep-wake cycle than adults do. And similarly, if you look at our older adult patients, they tend to have just the opposite kind of problem. And so why is it that you see these restaurants catering to our senior adults and serving half-price early bird dinner specials at 4 p.m. or 5 p.m.? It's because the natural circadian rhythms for older adults is that they do tend to go to sleep earlier, wake up earlier. It's sort of a myth that older people need less sleep. What happens is older people tend to not consolidate their sleep as well, so they're more likely to nap during the day and then sleep a little bit less at night. Plus, they're more vulnerable to having medical conditions, taking medicines, or having other kind of environmental stressors that may prevent them from sleeping as much at night. But we certainly wouldn't recommend to somebody, you're 75 years old, so you only need to sleep 4 hours a night. No, you're probably still better off sleeping 6, 7, 8 hours a night.
When you were speaking of the teenager and their sleep cycle, my son, even as a little one in school, he would be very, very sleepy. And he's an excellent student, so that wasn't the problem. Got excellent grades. He really had trouble. I started paying more attention, and he really couldn't sleep at night. He would go, once he goes to sleep, he's okay, but he would just take hours for him to go to sleep. But I never really realized because he wasn't a complainer. He would just go to bed. He didn't just lay there, but he went to sleep. He still does that.
I'm a big believer. I'm sorry. The comment again was having a child who sort of has never been a great sleeper, and academically doing well in school, enjoys school, but struggling because they're tired, and this has sort of been a chronic pattern, and paying attention to this. But it doesn't bother him, but it's the teacher where he's looking so sleepy. I'm a big believer in focus on function. So if somebody has a little bit of tiredness but otherwise they're functioning well academically, occupationally, socially, I'm a little bit less concerned about that than I am if I start hearing about people who are not only tired, but it's impacting their grades, or they're getting in trouble because they're falling asleep in class. If it's something like that, I think that warrants a little bit more attention.
Well, as he got older, he was tending more to, I would say sleep in class, but always I started to notice that the teachers every year would mention that. It's like, bed at night and all that. So I figured out, and now that he's in high school, with his fanatics with his sports and things, and so I don't think he does as well. He needs that sleep, but I don't see a change in wearing him out enough to put him to sleep. I really do think it probably does take a little toll.
Yeah, and if that's the case, that certainly would be a reasonable thing to get in and talk with a physician about, I think, because again, the first and foremost, paying attention to sleep hygiene. How much caffeine is he using during the day? Is his sleep environment? Because if it's like my kids are, it's like they're certainly not following good sleep hygiene when it comes to their rooms and what they do in there and having TVs and stuff. So being a bad parent there. But if so paying attention to the sleep hygiene, I think, first. And then trying to get an idea from them, have them do a sleep log, or you can do a sleep log for them and see what time are they going to bed, how long do you think it's taking them to fall asleep, asking them, hey, do you get up in the middle of the night? If you get up, how many times are you up? Why are you waking up? And how easy is it for you to fall back asleep? And then what time they wake up during the day and how they feel when they wake up. Kids can have sleep disorders. Kids can have insomnia. Kids can have sleep apnea. Even little skinny kids can have sleep apnea. Frequently because of enlarged adenoids or tonsils. Frequently because of allergies that can obstruct their airways. So it's certainly not impossible even for skinny little kids to have problems with sleep apnea. It's not terribly common, but it's not that uncommon.